I'm going to ask Judy, if you or Rachel could, we'll just do a roll call of the council members. So I could recognize a quorum and just indicate if you are present. And obviously I am present. And Judy, can you just go through the rest?
Yep. Frank?
Present.
Chris?
Present.
Father Alex?
Yes, present.
Matthew?
Present.
Francesca?
Here, present.
Linda will be a bit late. And Reverend Michael Smith? I think also will be a bit late. And then I can tell you who else, I don't think I missed him. Okay. Would you like me to tell you who else is on the call?
Yeah, sure. It'd be good for everybody to know. But first, I'll recognize a quorum with everybody you just mentioned. And then, yes, Judy, let's, rather than everybody introduce themselves so we don't have cross talking going on, just let us know who else is on the call.
Larry Zacharies, Carol Gomes, Nancy Toms, Nicholas Scabetta, Rob DeBrouwer, Adam Furtman, Carol Londoro, Charlie McMahon, Deborah Lowenklein, Ed Quinn, Kathy Byington, Ken Kashansky, Lynn Johnson, Peg McGovern, Marissa Trachtenberg, Matt Whalen, Maury Mcginnis, and I have one phone I think is Carolyn Kuby, maybe?
Carolyn's right.
Carolyn's there. Carolyn's there. So there is one phone only participant, and I.
All right. Well, it sounds like we have quite the full house. And did Judy miss anybody? If they did, you could let us know you're on the call.
Oh, here we go. I'm sorry, they're coming in more. Rickato, Shahir Khan, Susan Blum, and yeah, and I believe that's
And Rich Reader.
Rich Reader.
Okay. Well, thank you all. And Michael, thanks for having the whole team there again. The council always appreciates when the senior team is there for our meetings. We'll get right to the agenda. We're going to try to do the meeting in about an hour. It won't be as long as typical meetings, but I think an hour on a Zoom meeting is about the max time that it works well. I think everybody is going to be on mute. And when we need you to ask a question, if you have a question or if you want to say some words, Judy, there is a way for them to do that. Is there a hand raiser on the app here?
There is. So if you go to where it says participants at the bottom of most screens, there's a little raise hand icon. And you can just click that and we'll know that you have something to say, or of course, some people are throwing their hands up, but we don't see all of you on the same screen. So
right.
Click the raise hand icon.
Good. And by the way, if you do get that other password so I could log into my iPad and get off my phone, I'd appreciate you texting that to me. Okay, so tough to do a virtual pledge, so we'll just go to the approval of the minutes from March 2nd, 2020. I'll take a motion by Chris Hahn and a seconded by Frank Trotta. They've been circulated. Are there any additions, revisions, or comments? Hearing none. For council members, all in favor, we'll say aye. If you have an abstention, you could unmute your phone and, or Judy could unmute and you could let us know of any no votes or abstentions.
Aye.
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 Great. All right. Thank you all. The minutes are approved. So my chairman's report, very brief. As you know, we are living through probably the biggest healthcare calamity of our times. Not only the significant health concerns and the loss of life, including I had a member of my own family we lost 2 weeks ago. It's just terrible. It really has caused a lot of disruption to the entire university. And I've asked Michael and Judy that we spend the bulk of this meeting hearing about all the different aspects of what this COVID-19 has done to our campus, to our students, to our faculty, to our staff, and of course, the incredible burden it's been putting on our hospital. And we will hear updates on all of those impacts, activities, and plans for moving forward from Michael and the team, in a couple of minutes. But I think I speak on behalf of the entire council. While we haven't been on campus in a couple of months, we've been getting the updates. We have been reading about it, hearing about it on TV and the radio, and it really is mind-blowing what the entire team is doing over there. And we're also proud and we're also impressed that Stony Brook has really been like the premier leadership team on the entire island. And as we all know, we're really in the epicenter of this tragic crisis. So our hats off to all of you, and we look forward to Michael and the team's presentations and their reports on what the COVID is doing to our campus, to our region, and to all of our employees and students. So we'll get to that in a minute. The only other item I wanted to highlight and thank some folks is that, as you know, it was a year ago this month that Sam Stanley announced that he was moving on and to go to Michigan State. And we started a search process shortly thereafter for a new president. And I really do want to thank all the council members, especially those who served on the search committee, for all of your hard work. I want to thank the entire search committee. I got to know faculty and staff members who I really hadn't known since 11 years of being chair of this council. It was a terrific process, and getting to know all the other key people of our campus. I really want to thank Judy and Rachel as being the primary support staff to the committee and to me personally. They did a phenomenal job. I want to thank Michael for all of his leadership over the past year, for his friendship, his leadership, especially during one of the most disruptive and scariest times of all of our lives. And so, Michael, my hat is off to you. And I want to thank our Chancellor, Christina Johnson, who I work with regularly throughout this process, and her staff, and Dr. Merrill Tisch, the chair of the SUNY Board of Trustees, as well as Carrie Staller and some others for their guidance throughout the process. It really did result in a phenomenal new leader who is joining us today, and that is Dr. Maury Mcginnis. And Maury has agreed to join us from Texas as she winds up down there, and before she embarks on her trip up north and east to Stony Brook. And we're very fortunate to have her, and she's here today with us and is going to say a few words. So it's my pleasure to introduce Dr. Maury Mcginnis, our new president of Stony Brook University. Maury?
Well, thank you so much, Kevin, and good morning, everyone. This is certainly not the way that I wish we were meeting for the first time, but we'll do the best with a virtual meeting as we can. The last time that I saw some of you, those of you who are involved in the search process, was February 28th, which was when I had my campus visit. And at that time, while we certainly were hearing about COVID-19 elsewhere, we didn't understand at all what was coming to us as a nation, and particularly in New York and on Long Island. Kevin, I so echo your comments about the incredible work of the team at Stony Brook, and I am so appreciative of the leadership of Interim President Michael Bernstein and the entire leadership team. The work that Ken Kashansky and Carol Bowles have done on the medical side is really extraordinary, and there is so much for us to be proud of. I want you all to know that I'm already very engaged with President Bernstein and the entire leadership team, really kind of diving in on the scenario planning for fall and budgetary issues, as well as trying to get to know my team via Zoom, which again is not the ideal way to start new relationships, but I think we're doing the best we can under the circumstances. I want you all to know I'm so looking forward to working with Stony Brook Council. I'm so appreciative of your support for the institution, and just want to send the message that we will indeed get through all of this together. There's a lot of work left ahead of us, and we're gonna get through this together, and thank you for your support. Back to you, Kevin.
Hey, Maury, thank you so much. I'm going to tell you now, the first tale out of school. It was back in January, after a day long of interviews with prospective candidates. And after you left, Councilmember Chris Hahn came over to me and said, I think we just found our next president. And I said, I think you're right. And we're so happy that it worked out for you. And we look forward to you joining us soon. And the council pledges to work with you and to help you with a smooth transition. So thank you very much for joining us today. Are you going to stick around for a little bit of the call, or?
Yeah, no, I'll stay for the rest of the call. So thank you for that, Kevin. My family and I are really looking forward to getting up to Long Island. The plan is to move up there kind of mid-June. My kids are in school, if you call it that, here through the end of May. And so we're already starting to going through boxes and figuring out what makes the move and what doesn't make the move. So we'll be ready to go come early June when they'll pack up our house. So we're looking forward to joining you all.
Very good. Well, none of us move boxes, but we'll help you in spirit. And so we wish you good luck and a safe trip up to New York. Do any of the council members have any questions or comments for our new president?
I'll make one comment, Kevin, on your point. I was going to leave early that day because, it was 5 o'clock on a Friday and I had to get back to Stony Brook. And Kevin said, no, you want to stay for this one. And he was absolutely right. And I'm really glad I did. And I think you're going to be an excellent president. And I know that we're all really excited to have you here. And I think it's going to be a refreshing change from what we had the past 10 years. And I'm really excited to have you. So good luck and good luck moving. And I'm going to be your neighbor. I live about 100 yards from Sunwood. So see you on the beach.
Thanks, Chris. All right. Well, thank you, Chris. And thank you, Maury. Now I'm going to hand it over to Michael Bernstein again, who I can't thank enough for everything that he's done for the past year, what he's had to go through as well. And he's just gone above and beyond and has done a terrific job in steering the ship for the past year. And so, Michael, my dear friend, I hand it over to you for the president's report.
Thank you, Kevin, and good morning, everyone. And thank you, Kevin, for the kind words. And I know I speak for everyone when we say our thoughts and prayers are with you and your family, thinking of you and your loss in this terrible pandemic. And that goes for everyone who's struggling with loss and bereavement right now. And I also want to welcome Maury. Maury and I have been actively engaged with each other, and very much grateful for her support and full-on engagement in these ministries. I'll highlight a few areas of the written report that I provided the council. I'll focus my time then on our fall planning efforts, our fall semester efforts, and as Kevin said, we have some other speakers who I will hand off to who can update the council on our response to the pandemic and the public health emergency. First, to highlight a few points from the report, Dean Mary Trular has decided to step down as the Dean of Dental Medicine at the end of this fiscal year. Mary has been our Dean in Dental Medicine for 6 years. I want to thank her for her dedicated service, moving the School of Dental Medicine forward, particularly during a time of tremendous change at the university and within academic dentistry as a whole. Dr. Alan Cuisine, who's an associate professor and vice chair of the Department of Oral and Maxillofacial Surgery, will take on the role of interim dean as of July 1. Stony Brook University Graduate School made the top 100 list this year, ranked at 91 in the latest U.S. News and World Report edition on best graduate schools in the country. Congratulations to Dean Wertheimer and his team. Stony Brook University professor Heather Lynch has been selected by the American Association for the Advancement of Science as one of 12 researchers in the area of artificial intelligence to be a AAAS Leshner Leadership Institute Public Engagement Fellow. That'll be for the upcoming academic year. A great honor for Heather. A biochemistry major, Erica Nemeth, who will graduate next year, has been named a Goldwater Scholar, one of almost 400 U.S. students receiving this prestigious annual science award in the current year. 5 other Stony Brook students have been awarded graduate research fellowships by the National Science Foundation, very prestigious grants. Another 6 actually received honorable mentions in the competition. The successful applicants are supported in STEM disciplines with 3 years of funding for their graduate studies. We will host a virtual degree conferral celebration on Friday, May 22nd at 12 noon Eastern. That's our substitute for commencement, given that we're not in a position to hold an in-person commencement this year. We hope to be able to offer in-person convocations, as we call them, by school and college units in December of 2020 for our May 2020 graduates who are in a position and who would like to participate. So we're looking downstream to those events. So those are the highlight points from my written report. Let me turn to the pandemic and the public health emergency. It goes without saying, this crisis has hit our university in many ways. We have stepped up to that challenge. These responses have ranged from meeting the healthcare needs of our region to moving our current semester rapidly online so that our students will be able to finish their studies on schedule this May, and responding to an array of other issues that came before us. And people throughout the university and allied with the university have dedicated their time, their ingenuity, their hard work, their courage, and in some cases their own treasure to help us, meet these challenges. And I can't say enough with respect to my pride in and gratitude for all of these efforts from all the segments of our community. With respect to planning for the fall semester, key decisions must be made in the weeks ahead regarding our starting fall semester, regarding the restarting of our research, scholarship, and art-making enterprises, and an array of task forces and working groups have been set up to develop policies and to make operational decisions around a variety of issues, such as, I'll just call all of them out, give you a sense of some of the complexity of the things we're dealing with. Class size, required social distancing within classrooms, so-called course modality, that's one set of issues. enrollment management and orientation for our new students and our transfer students, a whole nother area, course delivery techniques, residence halls and how they will operate, food service and other amenities for our students, student and employee health needs, athletics, both intramural and intercollegiate, student life activities and events, as I mentioned, research, scholarship, and art making on behalf of the faculty and students, facilities and operations, events planning and rental of campus space, and finally, obviously, finance and human resource management, just to name a few. Our groups started working initially on what could best be described as responses to an emergency. They have now evolved into what might better be described as recovery task forces, looking at ways to ensure so-called business continuity and ways that the mission of our university may now move forward. All our task forces and planning groups are working in appropriate ways, I might add, to engage all the structures of shared governance that frame decision-making at our university. Entities like the University Senate, the leadership of the undergraduate student government, the leadership of the graduate student organization, as well as the representatives of the relevant collective bargaining units. All of these entities are being engaged within and across these task forces I've just mentioned, so we can make best possible choices and move our university forward through this challenge. And I'll conclude in this by mentioning we have a kind of three-tiered structure of planning. We start with these recovery planning groups that I've just alluded to, looking at return to work, information technology, facilities and space planning, academic planning, health and safety, communications, campus security, and so forth, as I've mentioned. There's a second tier of group, area task forces, looking at finance, enrollment, research, student affairs, and so forth. And then a senior executive group composed of the president and the senior vice presidents in all the key areas. So this is kind of the org chart, if you like, of recovery planning and implementation. All the groups, and I'll conclude on this point, all these groups are focusing their efforts around some guiding principles. So let me call out those principles. They're all on our minds, of course. One is social distancing. What do we do to create the appropriate space and distance in our respective environments to ensure public safety and health? Two, conduct on campus, not only with respect to social distancing, but face masks and facial coverings and so forth. What are we going to expect and require of all employees and students? Three, testing, tracing, and tracking. What are we going to do to see to the appropriate testing of our employees and students with respect to their health, as well as antibody testing and, of course, contact tracing if and when outbreaks occur among our university community. Administrative controls. What can we do administratively and with respect to operations to support all of our goals with respect to our mission and ensure business continuity and the appropriate functioning of our environments? And linked with that, what we call engineering controls, structural, mechanical, and other changes to support these planning principles and ideal goals with respect to public health and safety. And then finally, of course, infection prevention and planning. We have an infectious diseases group. We're getting advice from our leading colleagues over at the medical school and in the hospital. What are going to be the best practice invention prevention processes that we can implement across our campus? And what are the best epidemiological projections we have on hand to anticipate how this public health crisis will evolve, not only in the weeks and months ahead, but over the course of the next academic year and beyond. So that's enough out of me. I would like to have various colleagues share with you reports on our healthcare work and on the impact of COVID-19 on our university, on our budget and operations and so forth. I'm going to start with Ken Kashansky, and he'll be followed by Carol Gomes, the CEO of our hospital, Peg McGovern, the director of our clinical operations, and then Judy Griman is going to bring us up to date on state budget and other operational issues involving Albany and our campus.
Hey, Michael, before we get to the rest of your team, could we just see a couple of questions for you?
Oh, okay, great.
Sure. In fact, I'll start. When you were listing all the different activities and issues that you have to plan for, it really is amazing. You know, Stony Brook is like a small city, and you're like the mayor, and anything that's impacting a particular city is impacting our college, and then a whole bunch of other issues. So it really is amazing the logistics and the planning that will need to go, that need to be taking place. So thank you for that thorough update. I had two questions. One, and feel free to punt it to any of your team members. Are we seeing any type of uptick in transfer students for kids who their parents perhaps don't want them away at colleges, not knowing what's going to happen in the fall, and they perhaps registering at Stony Brook to be commuter students as opposed to going away to school?
So, Kevin, I'll mention something and then I'll answer your question directly. Your point about all of these groups I mentioned, you can see, I think the members of the council can see the interconnectedness of everything we're doing. You know, if you change enrollment because of issues around this pandemic, you're changing finances. If you change finances, you're changing research and education. You're changing research and education, obviously you're changing our mission. Everything is interconnected. You know, the proverbial game of whack-a-mole. Anything we move on one part of the board is going to change something on another part of the board. That's the complexity here. Your question about transfers is timely. What we're seeing, our biggest challenge with respect to enrollment planning for the new class that comes in the fall is with respect to international students. For obvious reasons, applications are down, commits are down from international students. We also see some weakening with respect to domestic out of state. We're seeing an increase, therefore, in New York State students in the mix. We're expecting a more New Yorker class in September, although the numbers are still changing. Transfers is also, a mixed bag. Obviously, transfers tend to be more local students. That works in our favor. Other transfer students are dealing with economic questions that may affect their decision whether they want to continue their studies this fall or not. So it's still very much up in the air, but overall, I would say we do not anticipate a problem in filling seats for September. We do see a change in, to use a phrase from the medical world, we see a change in the payer mix with respect to where the proportion of students and where they come from, and therefore what fees and tuition they pay.
Got it. No, that makes sense. And my last question is, in terms of the decision to stick with the fall semester schedule for the first day of classes, and whether they'll be remote or in person, is that going to be a SUNY central decision, or will that be left up, or will that be done perhaps by region, like the governor is looking to perhaps open upstate New York earlier than downstate New York?
Great question, Kevin. So first of all, Maury and I put out a communication to the university community, which I think all of you saw about a week ago, that explained some of our planning efforts and said at the moment, we do not anticipate making a final decision until the latter part of June. Part of that is because time is our friend in the sense that it gives us more information. And obviously this public health crisis is rapidly evolving every week. Whatever decision we make, and we do think it's a decision that the campus will have to make, it has to be made with reference to whatever the governor's directives are from Albany. And we expect those directives will vary regionally, depending on how this pandemic evolves in the weeks and month or two ahead.
Got it. And that makes sense. Thank you, Michael. I'll open it up to other council members for questions for Michael before we get to the rest of Michael's team. Any other council member have questions?
Michael, with regard to the international students, what's going on in that area, particularly with the virus?
So thanks for your question, Frank. So first of all, I mean, months ago, we started to see some weakening in applications from overseas. Some of that, predates the pandemic. Some of that was political. Some of it had to do with perceptions of the so-called political climate in the United States. With the pandemic, there was further weakening in applications, and we continue to see some weakening now in so-called commitments from students. Part of the problem is a lot of uncertainty, one, about travel. Will people be able to travel? And two, initially, although now INS is beginning to resume operations, the processing of so-called F1 visas, which the students need, had been shut down by executive order. So that threw another layer of uncertainty, but they're starting to resume processing of F1s. And again, I would expect in the weeks ahead, the situation will continue to evolve. Overall, we are anticipating, a drop in international enrollment for this September.
Good. Thank you, Michael. Let the record reflect that Councilmember Linda Arman has joined, and I believe Michael Smith has also joined. Is that correct?
Let's see, Michael.
Well, Linda.
Yep. Hi.
Hi, Linda.
Hi, Linda.
Thanks for joining.
Yep.
Okay.
Sorry about that.
Any other council members have questions for Michael Bernstein? Okay, Michael, thank you very much for that very thorough report. And as you mentioned, we're now going to hear from Ken Kishansky, and then Carol Gomes, and then Peg.
Correct.
Thank you, Kevin, and thank you all to the Stony Brook Council. Needless to say, this has been a very interesting time in the full spirit of the Chinese proverb for Stony Brook medicine. And first, I'd like to sort of give a thumbnail of what's been going on in Suffolk County and at University Hospital before turning things over to Carol to talk about hospital preparedness and Peggy to talk about our outpatient, our staffing, and our return to what will become the new normal. But first, you should know that although a lot of hoopaloo has been around New York City, the infectivity rate here in Suffolk County is every bit as high as the average of all of New York City. So we did not escape anything by being geographically removed from that density that is New York City. About 17% of our people and of Stony Brook and Suffolk County as a whole are testing positive for the antibodies that show infected by the virus. First person under investigation, or PUI as we call people, who come in with symptoms suggestive of COVID-19 disease was on February 7th. That person turned out to be virus negative, but the first confirmed case at Stony Brook was on March 8th. So perhaps just a word about testing, because there's two basic types of tests. There's tests for the RNA of the virus, usually in the nasopharynx or more recently saliva or the back of the throat swabs can detect the virus. That tells you you're infectious, that you have the virus, and you may develop full-blown COVID-19 disease. The second basic type of test are antibody tests, which will tell you you have been infected anywhere from a week ago to months ago. Unfortunately, the antibody tests that are currently available don't tell us whether you are actually immune, whether you're actually resistant to infection. They don't tell you whether you can or cannot spread the virus. So those tests, two different types of tests, important to know about. Anyway, back to the disease at Stony Brook Medicine. Thus far, we have seen about 6,700 persons under investigation. Close to 60% of them turn out to have the virus. So we've seen about 4,000 people at Stony Brook Medicine, and that doesn't count the Department of Health supported testing that's going on out in the South P parking lot. So about 4,000 people have been viral positive at Stony Brook. About 1,200 of them or so have been admitted to University Hospital, and about a quarter of them either are admitted straight away or are ultimately decline and get admitted to our intensive care unit. And virtually all of those patients, or 95% of them, 95% of them, need mechanical ventilation. So in a moment, Carol will talk about how we have prepared for that surge of patients that we saw. And just so you know, our maximum, we had 437 people in University Hospital who were demonstrated to have the virus or were likely to have the virus at the peak, which I think was April 10th. And then we'll hear from Peggy, our Dean for Clinical Affairs, about how we staffed for so difficult a surge and how we're transitioning back to normal. So I want to just talk about two aspects of it. One is our results. How have we done here at Stony Brook Medicine? And that is a function of two major elements. One is the hospital's preparation, and two is the skill and devotion of our faculty and staff. The second topic I'd like to just briefly brush on is, since we are the premier academic medical center on Long Island, it's our responsibility to study all possible aspects of this epidemic so as to set the standard for best possible evidence-based care for all patients, and to learn as much as possible about the various aspects of the disease with an eye towards translating that knowledge into our patients and everybody's patients. So what about the outcomes? If you look at Suffolk County mortality data across the 11 hospitals in Suffolk County, our three hospitals, Stony Brook University Hospital, Southampton Hospital, and Eastern Long Island Hospital, have the three lowest mortality rates of the entire county. So just by numbers, our mortality rates are about 7.5%, compared to about 15% countywide. And Northwell Health published a paper about 3 weeks ago, 2 or 3 weeks ago, on their outcomes across their entire system, and their mortality rates were close to 20%. So we are doing well, and I attribute that, like I said, to our hospital's preparedness and to the skill and devotion of our faculty and staff. Also, those sickest of sick patients, the ones in the ICU, our mortality rates in those patients are about half that seen in other healthcare systems. So again, very good results in our hospital. We're also I think we are taking good care of our healthcare workers. Our faculty and staff are on the front lines. As I said, the average rate in Suffolk County is 15 or 17% of the people of Suffolk have seen this virus up close and personal, so to speak. And that's about the rate of the people who are working as healthcare workers at Stony Brook, meaning you're just as likely to become SARS-CoV-2, the virus, become virally exposed working as a healthcare worker at Stony Brook as going to Stop and Shop and buying your groceries. So the efforts with PPE, with personal protective equipment, the efforts with keeping our people safe have been quite successful. Then finally, I just want to touch on what we're doing in our responsibility for research. We are standing up a data commons that will bring in all the data from the electronic health record, from the notes, from everything, all the imaging, all the pathology, to make available to all of our faculty and staff the ability to do IRB approved clinical research. And that single source of truth, if you will, is going to be very, very important for us to study this epidemic in Suffolk County. The second thing is we have been involved or are leading about 8 clinical trials right now of various treatments or natural history studies of the infection. Just to mention a few, you've heard of remdesivir. This made the news in a big way. An NIH study reports that the length of disease, of severe disease, has been shortened by the use of remdesivir. there's a strong suggestion, although not yet proven statistically significant, that it's reducing mortality of the disease, and we are part of a remdesivir trial here at Stony Brook. We have another experimental drug that's being used to reduce the inflammation that is so characteristic in these patients. We have launched a randomized clinical trial, one of only 4 in the country, to test convalescent plasma. That is, people who have recovered from the virus and are now presumably immune to the virus use their plasma to treat sick COVID-19 patients. We're randomizing. 4 patients will get the convalescent plasma, 1 patient will get placebo plasma to test whether this treatment really works or not. And we have a number of other clinical trials that are being launched. So I think from a clinical perspective, from a research perspective, we are working 24/7, 365 in an effort to bring this epidemic in Suffolk under control, or as best as we can. So let me turn things over to Carol. Kevin, you want to maybe just do questions at the end of all 3 of us? Or?
Yeah, Ken, that makes sense. Let's get through Carol and Peg, and then if any council members have questions, the 3 of you can handle them.
Great. Carol.
Thank you. Good morning, everyone. First, Kevin, I'm sorry for the loss of your family member. Very sorry about that. So, Ken, thanks for setting the stage and providing a foundation for some of the comments that I'm planning to make. You had mentioned at the height of the crisis that we had greater than 400 positive patients in-house, and I can say today at our morning huddle, we had a count of 180 positive patients. So we are really seeing a significant decrease in the number of positive patients. And in fact, we started discussing the fact that we have more non-COVID patients now in the house than COVID patients. So that is quite a positive note to start with. So we're currently at day 64 of our hospital incident command system structure in terms of utilization. This is an organized structure that basically provides leadership in key areas of focus. We discuss activities that occur within the medical branch, within logistics, within supply chain management, staffing. It basically allows us to manage any type of a crisis. And typically, we open our command center for hurricanes, planning during snowstorms, or if there's a utility outage. But this is a very, very different experience, one that many of us in healthcare over the last few decades have never experienced. And it's just an extremely prolonged and complicated crisis. So with that came a lot of planning. We've had a lot of challenges along the way, whether it's a focus on the availability of supplies, the availability of pharmaceuticals, PPE or personal protective equipment, which I know you've heard about in the news. So the focus of this hospital incident command center is really to garner the resources that we need to be able to plan through the crisis proactively. And I have to say, I'm really proud of our Stony Brook medicine team for being able to do just that with our partners at Stony Brook Southampton Hospital and Stony Brook Eastern Long Island Hospital as well. So we have those ongoing daily report outs both in the morning and then subsequently in the afternoon, and discuss all of those activities. Obviously using CDC and Department of Health guidelines as our beacon of light in terms of areas of focus for public safety and public health. And early on in the process, the governor had requested for hospital CEOs to increase the capacity for hospitals to accommodate the potential surge that was coming our way with COVID positive patients. So at first we were asked to increase our capacity by 50%, and then subsequently the request was for 100%. So you can imagine if we review the Stony Brook medicine system, each of the 3 hospitals, we all had to develop plans for surging. So at Stony Brook University Hospital, we have 624 certified beds, and we developed plans to accommodate patients in the surging process in very untraditional places. We planned to and did open areas that we typically would not see inpatients in: our ambulatory surgery center, our ambulatory care pavilion. we were planning to surge into our Medical and Research Translation Center, the new MART that we opened, which is a primarily outpatient-driven cancer center. Various other outpatient locations had plans for surging as well, and we did execute and implement many of those. On a daily basis, our team would huddle, and we would discuss each expansion plan in a series of steps and address the staffing issues, the ICU capacity, which was significantly increased. In fact, we have currently 85 certified ICU beds, and we surged well near 300. It was closer to 270 plus ICU beds at the height of our crisis. So really significantly accommodated and addressed that surge capacity that was much needed in order to address the patient load. So with that, we did have this planning process, and it incorporated ancillary services, respiratory care, our ICU physicians, and Todd Griffin, actually our chair of OBGYN, but also previously a CMO leader, really understands hospital operations, stepped up to the plate working with Dr. McGovern to manage these huddles and manage the surge capacity with our physical plant team in order to continue the growth over that 12-week period to satisfy those needs. Southampton and Eastern Long Island also developed plans and also expanded their surge capacity. Very proud of the work that they've done. Many of our COVID patients obviously required ventilation and also required oxygen. And so very early on, we recognized the fact that we needed to address and accommodate a surge capacity with oxygen storage. And so with that, we developed an oxygen tank farm, created one, working with our physical plant and our partners, and doubled the capacity for the availability of oxygen on our campus. We did this well ahead of the curve. It was several weeks before the surge actually occurred. And so it really positioned us quite well for being able to serve that patient population and ensure that we had appropriate oxygen levels to monitor and provide treatment for those patients. Just prior to hitting our peak volumes, also, we were working with university officials, the governor's office, FEMA, Homeland Security, the Army Corps of Engineers, Homeland Security. I'm sure you've heard in the papers, the building of the field hospital. And so that actually was completed within 21 days. Obviously, we didn't use it, but it still stands at the university, and really would like to thank our university partners, particularly Judy, who really helped to lead that effort, working with Kathy Byington and others, and Larry Zacharies, of course. In addition, staffing obviously is a challenge. If you have this patient surge, you need to accommodate with staffing, and these are much higher level acuity patients. They're sicker. They require more intense effort in terms of staffing. And Dr. McGovern will tell you a little bit about the focus on the labor force and how we were able to accommodate that. But as we pooled those resources that were basically rescinded for elective surgery and ambulatory care, we basically pooled those resources in order to care for the patients who were coming in and addressing that need. But obviously staffing was a challenge. We were able to supplement with agency nurses as well. And then I'm sure you've heard in the news, our sister hospital, SUNY Syracuse, sent 3 basically cadres of staff to us, ICU and ED nurses, respiratory therapists, pharmacists, pharmacy techs, really helping to provide a richer staffing pattern for us. And it was very appreciated, and we really, from the bottom of our hearts, really appreciated that effort and the camaraderie associated with helping us to get through this difficult time. Very, very grateful to Bob Corona as well, the leader there at SUNY Syracuse. In terms of caring for COVID positive patients early on, we formed a strategy and clinical guidelines group. And I think that that's what Dr. Koshansky was referring to earlier in terms of providing the best outcomes we can for those patients. So There were physicians who scoured the literature, spoke to colleagues in Italy and spoke to colleagues in China, Washington, England, to get a sense of what the best focus was for clinical guidelines and how we can treat these patients to obtain the best clinical outcomes possible. And that information was basically translated into written clinical guidelines and protocols and order sets that were quickly utilized, and we educated, and I say we, but Dr. Voswinkel, Dr. Mansour, Dr. Nachman, Dr. Harris, Dr. McGovern, the entire team really working together to educate physicians to provide standardized care so that we would provide the best guidance in terms of medical guidelines possible for these patients. So obviously the use of evidence-based literature helped us early on. And again, this was an early effort, which I think translated into good outcomes for our patients here. You also probably have heard that there was a ban on elective surgeries. And so that does continue here in Suffolk County because this is one of the hardest hit areas. The state is looking at HERDS data, which is data that we input into the system, the Suffolk County system that rides up through the state system so that you can understand exactly what's happening in any part of the state. And we utilized the data from April 17th through the 27th to make determinations as to whether or not we would be able to address the elective surgeries here at Stony Brook. And at this point in time, we're still in a hotbed area. And so therefore, we do not meet the criteria to be able to resume elective surgeries. So we are focused only on those life-threatening surgical procedures. And we have a very tight control over the types of procedures that we accommodate in the operating room. But we are continually looking forward and prepared to pull the trigger when we're able to accommodate those surgical procedures, and looking forward to moving forward in that respect. We've also implemented many programs for patients and their loved ones. Obviously, it's a tremendous challenge. It struck me the day that I entered the parking garage and I saw the SCALA sign that said no hospital visitors. And never before have I seen anything like that. And obviously, when you're dealing with a very sick patient population, it's difficult to tell a loved one that they're not able to visit their loved one in the hospital. So the staff really rose to the occasion. We have a patient advocacy team that has developed all types of programs working with nursing and other colleagues here at the hospital to develop ways that we can better communicate with those families. We have iPad programs. Many community members donated iPads. We're very grateful for that to improve and enhance communication. We developed a family liaison program that allows for the ability to connect with family members to provide more frequent updates, which was a challenge early on. If you can imagine being on a unit, having staff that are not necessarily accustomed to wearing and donning face masks and N95s and gowns, and then having to run to the phone to answer it, it wasn't something that's typically very easy. So programs needed to be developed in order to accommodate and address family communications and needs. So we're really proud of that aspect of care. The team also developed something called My Story, which you may have seen in the news, where we reached out to family members of patients who are here who aren't able to speak, or who may be vented and having difficulties from a care perspective. And basically, it's a beautiful biography with photos of their family, what hobbies and interests they have, what perhaps they do for a living. And it really provides a connectivity between the healthcare provider and the patient who is unable to speak for him or herself. So it was a very touching program that we were very proud of as well. I've seen staff holding birthday celebrations for patients, really touching times, and really warmed my heart to see how the staff comes together to care for our patients. And then speaking of staff well-being is of course one of our top priorities. We created a respite space. We call it the Sanctuary on our 12th floor. It was one of the units that we had closed early on. And we have aromatherapy, we have psychologists available, we have crisis intervention teams. We provide safe respite for those frontline workers, or any worker for that matter, who needs to take a break from that day-to-day care and find a place where they can talk to their colleagues and just rest, have a drink or a snack of some sort, and take a moment away from the unit. In addition, the community has been a tremendous partner. We've had food donations, chalk drawings, all types of video clips sent to our team members to thank them for the support that they're providing for our patients. It's been just an incredible outpouring of love, and we really do appreciate it, and it keeps all of us going. And most notably, the support of Stony Brook University and the leadership there. Cannot thank Judy Greiman, Dr. Bernstein, and the entire leadership team, Larry Zacharies, Dr. Kashansky, who's been a steadfast leader through all of this and has provided incredible support, Dr. McGovern, and our entire leadership team. I could go on and name everyone's name that's been supportive, and I'd be here for a long time, but just so grateful to be a leader here at Stony Brook University Hospital and part of the Stony Brook Medicine family and the university. And it's really been a proud moment for all of us. And we look forward to the next phase. I think Dr. Bernstein mentioned recovery phase and the business continuity phase. And we're certainly in the throes of that here at the hospital as we plan to move forward with our strategic planning efforts. So I just wanted to thank everybody for this opportunity.
Thank you so much, Carol. I think your report just confirmed that Michael Bernstein's best decision he made while interim president was making you the permanent CEO of the hospital. We're very lucky to have you, and thank you for that thorough report. And now we'll hear from Peg McGovern, and then we'll take questions from the council.
Thank you. I actually do have an office, but I'm going to one of our outpatient sites. So I'm in my car, but I'm not driving, so it's all safe. So thank you for giving me a few minutes to give you an update a little bit on how we accomplish that physician staffing and how we're managing our outpatient environment. So as Ken and Carol both mentioned, the governor called on hospitals to increase their beds at Stony Brook University Hospital. Over a 2-week period, we added 355 beds, doubling our ICU step-down beds and increasing some floor capacity. This is a huge task, and so an expansion team was assembled, led by myself and Dr. Todd Griffin. We meet twice every single day, and we've had the authority to manage the opening and staffing of all new units, including the redeployment of personnel from every department. So we accomplished the increase in beds by repurposing medical and surgical units, the ambulatory surgery center, both the preoperative and postoperative units, the cardiac care center, and the outpatient cancer center. In addition, the Children's Hospital and PZD began to see patients up to age 30, including many COVID patients. So staffing all those incremental beds was frankly a monumental task, and it really required us to rethink all of our existing paradigms and use every resource at our disposal. And it affected every level of organization, from attending and resident physicians to advanced practitioners and even to our newly graduated medical students. One of the first things we did was to seek and were granted the pandemic emergency status from the American College of Graduate Medical Education. And this allowed us to mobilize all of our residents and permitted our fellows to act as attendings in their core specialties. So a fellow in adult gastroenterology is a fully trained internal medicine physician, could function under this status as an attending in internal medicine. Residents from every program were then classified with regard to their level of ICU experience and combined with our advanced practitioners, that being NPs and PAs, to create what we called clinically equivalent teams. These teams were then deployed to COVID medical floors, step-down units, and ICUs based on their experience. We also hired our newly graduated medical students, those of whom volunteered to take on this position, which was 52 of them. And they were hired as assistant attendings and paired with medical residents to staff our non-ICU units. Medical attendings and fellows from across the inpatient and outpatient services were assigned to supervise these teams in the medical units. But really, the severity of this disease has meant that the largest burden has fallen on our intensive care units. In addition to all the equipment and supply chain issues that Carol spoke about a bit, we really had to think outside of the box about how we could safely manage this large influx of extremely sick patients. And, our intensivist pool of intensivists is a finite pool, as you can imagine, but we pulled in every credentialed intensivist in our entire organization, including some in our employed physician group, and from every department across the School of Medicine. And each of these intensivists was then assigned to supervise 2 clinical teams consisting of a non-intensivist attending or fellow paired with one of the clinical equivalent teams. So this arrangement allows us to better utilize the knowledge and experience of our specialists while also ensuring at all times there was direct supervision of each patient through what really was like a pyramid system. Our surgical and medical intensivists, also in collaboration with the team that Carol had referenced, created the clinical care standards and protocols to ensure that all patients were getting a similar level of care. We also created a very sophisticated Tableau dashboard so those intensivists could get a great snapshot of how sick the hospital was, where the sickest patients were located, and then the leadership in that group would go and round in those units and make sure everyone was sticking to the plans that we had promulgated across the organization. And there is no doubt in my mind that process and that discipline that we brought to it contributed to the great outcomes that Dr. Kashansky referenced at the beginning. These clinically equivalent teams of residents and advanced practitioners were working 5 days on, 5 days off, and the attendings working 7 days on, 7 days off. So why did we choose that schedule, which I think has served us very well? First of all, it really has helped to reduce physician fatigue and burnout, particularly in the ICU setting where the care has been very intense. And Carol talked a little bit about some of the support we're giving to our staff, but there is no question that this has been incredibly difficult and traumatizing time for the doctors taking care of these very sick patients and seeing so many patients have to be cared for in such an intensive manner and so many who have died. This overlapping coverage also allowed us to ensure continuity of care, which was very, very important given the acuity of the level of care these patients needed. The deployment of all our residents and fellows, for those of you who are familiar with hospitals, residents and fellows are assigned to all units of the hospital. They do a large amount of the clinical work under the supervision of attending physicians. Well, we took them all away from all the departments, which meant that with limited exceptions, all of the clinical departments in the hospital had to fully cover their services 24/7 with their attending physician group. That is a fundamentally different model for an academic medical center. And we are so grateful that our attending physicians, our full-time faculty in the School of Medicine really stepped up to the plate and have been covering their services 24/7 without any attendings or fellows helping in that work. This rapid spread of this disease, as Carol also noted, really required every part of the hospital to step it up, from procurement to facilities, to nursing. And I've told you a little bit about the physician adaptations, which were complex and difficult, but we had a lot of tools in our toolbox and we accessed all of them. I really give a lot of credit to nursing that, didn't have a pool of residents or fellows or outpatient docs to pull from to staff up their units, and they've just done an outstanding job. So they deserve a lot of congratulations. I also want to talk to you a little bit about what are we doing in the outpatient arena, since, frankly, more care is delivered in the outpatient environment than in the four walls of the hospital. As Carol had noted, in response to the governor's executive orders, all routine types of visits were canceled, and that included outpatient visits at the start of the crisis. So we canceled all annual physical exams, routine eye exams, annual mammography, et cetera. All of these types of visits were canceled. And just to provide you a little bit of context, Stony Brook Medicine, across all its entities, operates over 200 outpatient sites, delivering approximately 4,500 visits a day. By March 23rd, this volume had declined by 75%, and by March 30th by 90%. That was in part the cancellation of all the elective visits, and also patients starting to cancel their visits because of their concern about leaving their homes and getting exposed. At the same time, we rapidly expanded our telemedicine capacity. So we trained a cadre of navigators to assist both our providers and patients in the use of a telemedicine platform that we selected, which is the Teams app. The hospital granted emergency telemedicine privileges to 500 physicians. And we developed a education program on the use of the app, all of the compliance issues associated with telemedicine, and how to properly document and bill for the visits. Similarly, patients were called by the navigator to make sure that they could use the app, and our medical students had some had volunteered to start teaching patients who were still in the hospital how to use the app, so when they went home they could access their follow-up care through telemedicine. To date, we've delivered over 30,000 telehealth encounters, which is a huge number for us because really our telemedicine visits before this crisis were on the order of maybe 1,000 a year, and mostly in the Department of Psychiatry. And we've increased the volume of those telehealth visits every day. So for example, last Thursday alone, we had 1,400 telemedicine visits. And we applied for and are waiting to hear about a decision on a grant we submitted to the FCC to purchase $1 million in telehealth devices that would allow even more sophisticated telehealth visits to occur. So right now what we have is video and audio connection with the patient, but these devices that you give to selected groups of patients can actually transmit back to the physician who's having a visit with them, their heart sounds, their breath sounds, even an EKG strip. It's a way to report blood sugar if you have diabetes. So there's a lot of sophisticated clinical information you can gain while the patient's sitting in their home, and we'll distribute those kits to patients with chronic diseases. Well, now we are in the difficult process of reawakening our outpatient environment to the extent that it can be. We and others have noted that non-COVID patients who are now presenting to our hospital are very sick. They've been putting off seeking care during the pandemic, and many of them have experienced a deterioration in their health status. So that is obviously not an outcome any of us want. So we are being very proactive now about reaching out to our patients. We sent 120,000 messages through our patient portal to our patients with chronic disease. We're sending emails to every patient who's provided that information to us. And every single area is making direct phone calls to patients to reach out to them, check in on them, remind them if they have a chronic disease such as diabetes, congestive heart failure, rheumatoid disorders, etc., that it really is important for them to come in for an in-person visit with their physician, and we're starting to schedule those appointments. We've put together a very thorough plan to make the outpatient sites as safe as humanly possible, and hand in hand with that, a communication plan designed to reach our patient base, but also our providers and staff, to let them know that we're prepared to safely meet all their healthcare needs. So the kinds of measures that we're going to be using, having markedly expanded hours to reduce the density of patients in our outpatient environments. Our goal, anyway, it's my goal, and I keep telling everyone it's all of our goal. Our goal is that no one's to ever be sitting in a waiting room. So the density should be spread out. Patients can check in for their appointment from their car, and then they're called from the front desk when they're actually ready to go directly into a room. So just to reduce this crowding, everyone, staff, patients, providers, everyone's wearing a mask in every outpatient environment. We do symptom screening of patients. So they get a phone call the day before their appointment. If they're symptomatic for COVID, they're diverted to COVID-specific outpatient sites. And when they arrive for their appointment, they're again asked a series of questions. All similar to the hospital, no one's allowed to bring anyone with them for their visit except in pediatrics, frail, elderly, developmentally disabled patients, etc. And we're doing some modifications to our physical environment, including putting up plexiglass in front of all of the reception areas and everything that we can do to keep these environments as safe as possible. So a lot of work going on to reopen that outpatient environment, do the in-person visits for those patients who really do need now to touch base with their physician. Testing is going to be a part of this strategy, but that testing has been a very rapidly evolving platform, both in terms of access to the reagents to do testing and guidance from the CDC about who should and should not be tested. At the moment, we are testing any patient who is scheduled for any type of procedure. Either in or out of the hospital, is tested the day before their procedure. If the test is negative, they can continue and have their procedure done. If they test positive, unless it's urgent, the procedure is rescheduled. And if they do need the procedure, it's done in an appropriate, safe room with negative pressure. So that's a lot of the work that's going in the outpatient environment. And I just want to take a minute to tell you a little bit about some work that Stony Brook Medicine has been engaged in over the past 18 months, which really has helped us meet some of the challenges that COVID has brought to our doorstep. And that work has been in the developing of a clinically integrated network. So a CIN it's a legal mechanism actually, but it requires a structured collaboration among physicians and hospitals through an active and ongoing program designed to improve quality and efficiency of healthcare. And I think that some of the work we did in laying the ground for our CIN has helped us respond so nimbly to this crisis. Some of the pillars of CIN are care management, and now we've redeployed our entire CIN care management team to manage the care of our COVID positive patients who get discharged from the hospital to make sure they get all the follow-up they need, that the testing's being done to clear them from an infectious disease perspective so they can come back and have procedures they may need. And this has been a great resource that we had put together that team. Another pillar of the CIN is patient access. And all of the work and investments in IT infrastructure that we stood up to support patient access is exactly what's allowed us to now reach out so quickly to our patient base, let them know what we're doing, touch base with them, tell them that, we're concerned about their health and making sure that we're getting to see them. We also had put together a program for the management of post-acute care, a post-acute care collaborative, and we are now leveraging that because there is no question there's going to be a significant number of patients with this infection who wind up needing significant post-acute care resources to manage them in an ongoing manner, including some patients who are going to wind up on long-term ventilatory support. So that is important groundwork that we'd already been out in the community, making those partnerships, and now we're leveraging those so that we can place our patients in appropriate settings. Hospital efficiency projects, also part of CIN. And back when we had the luxury of thinking about things like how we utilize IV Tylenol and blood bank utilization, now we're really using the skills we built in hospital efficiency to really help us respond to this really unprecedented crisis. But the biggest part in the center and heart of the CIN is delivering high quality care. And I think that the numbers that Ken spoke to about our outcomes and that Carol spoke to about how our physicians quickly came together to develop these care protocols and power plans that are really updated. Things move so fast in this whole crisis that it's actually things that we would have deliberated about a year ago. In old times, people are making these decisions very quickly in a couple of days, coming together, rapidly coming to consensus, and pushing out here's the best quality care that we should be providing to these patients. And all of this infrastructure really has, I think, served us well. And when we get back to whatever, normal is going to look for us in the future, the CIN is still going to be an important architecture for growing the Stony Brook medicine programs. We became a Medicare ACO on January 1st of this year. Thankfully, given all that's going on, CMS has basically told all ACOs that they're not going to be held to any particular measures this year because it's very, very difficult to be doing what you're supposed to be doing when can't even see your patients in the outpatient environment. We can't do elective procedures. We also had entered an at-risk financial program, the CMS BPCI program. So this is a bundled payment program. We entered that on January 1st for acute MI. We've continued that work through this crisis. CMS has noted their intention to hold participants in that program to their metrics this year. And that would be appropriate because, of course, you don't want people with acute MI doing worse during the COVID crisis just because this crisis is going on. I had mentioned that we formed that post-acute care collaborative, which is going to serve us very well. And we had formed an IPA to start to engage more with physicians in the community. And I can tell you that, the physicians in our community have seen how Stony Brook Medicine has really stepped up to the plate, been an important resource. And I think that this entire episode will only make the IPA more successful because they're seeing that Stony Brook Medicine is the health system they want to be associated with. And all of the IT investments that we made were there and in place, and we actioned on it very quickly. So again, very good investments that have made as part of the CIN that have served us well in this crisis. So that is my report. Happy to take any questions.
Well, thank you so much, Peg. It really, I thought it was mind blowing when Michael ran through the list of all the different activities that had to go into place for planning for reopening the campus and then for the students. And then hearing from you and Carol and Ken on all the different activities that and major decisions that you guys had to make over at the hospital. It really is just mind-blowing and so impressive. You really have been operating a war room in a war zone, for the last couple of months. So very impressive. I know there's not a whole lot of time left, but I just had two quick questions, and whoever wants to answer it, and then I'll ask other council members, because we do have one other item we have to get to at the end of the agenda. Is it likely that the hospitals that the Army Corps of Engineers built, they'll stay up at least until we know if we're going to get hit with the second phase this fall and winter? And do you believe we have enough PPE to take care of all of our staff for the remainder of the year?
So perhaps I'll just take a first shot at it. As you correctly point out, Kevin, we were being driven by the governor to be prepared for doubling the number of hospital beds, and we were very concerned about that, which is why we were enthusiastic that the U.S. Army Corps of Engineers were coming to create that 1,034-bed hospital on campus. Because of all the planning preparations that you heard from Carol and from Peggy, it turned out we never even got close to really needing that. It was not essential. Will the next wave be worse? Probably not, but having it over there just in case, not just for us, but for the surrounding hospitals might be appropriate. So I don't think any of us would like to see it rapidly deconstructed. It should be maintained. A lot of work went into it by them, by our leadership to make it ready for patients. But I don't think we'd want to see it dismantled yet.
Good. And then what about the PPE, Ken?
Let me turn that over to Carol. She's the most pessimistic of all of us about PPE. Carol, what's your thought?
Well, we've done everything that we could within our control to create PPE, working with our university partners, specifically the 3D face shields. However, we are having difficulty securing some of the PPE, medical gowns, some special sizes with N95s. So I have to say, I have to give credit to our supply chain management team. They work the phones pretty much 24/7 because they're also working with folks overseas to try to identify vendors that will be reliable to send and have availability of shipments. It's just, it's an international issue. There are shortages and, we're working hard.
Carol's comment, just so the council knows, Carol's comment about reliability is we were offered a million gowns, and they were normally cost us 32 cents. And they were offered $10, minimum ordered a million. And of course, that company turned out to be quite bogus. So not only have we had to get gowns and face masks and N95 masks, but we've had to sort through, the wheat from the chaff, if you will.
Got it. Thank you, Ken. Any other council members have any other questions for Ken or Carol or Peg?
I'd like to ask a question, Kevin. It's Matt Cuomo.
Yes, ma'am. Hi, Matt.
Hey, how are you guys? There's a question for Dr. Kojanski. During your comments before, Doctor, you'd mentioned a 17% positive rate, and I just wasn't clear. Is that 17% positive on the tests which are checking to see if someone is sick, or is that 17% positive on the serology test searching for antibodies? What's the difference?
So it's the serology test. How many people have ever seen SARS-CoV-2 virus? How many have ever seen it since it first arrived on our shores in January to the day of testing? So it doesn't mean you're sick. It doesn't mean you're infectious. It doesn't mean anything except you have been exposed to the virus and it took root in you and your immune system responded to it.
And is that an actual number or is that an estimate, that 17%?
It's an estimate based on large populations where everybody gets screened. So we've actually done that here at Stony Brook. We've taken 500 healthcare workers and screened them with the antibody test, and it was about 15 or 17% were positive. The health department has done that with other swaths of Suffolk County and find a very similar number.
And just one more thing, for the people who tested positive for the disease while sick, so I guess that's if you went in and had the swab test, what was the percentage of positivity for those who came in thinking they were sick?
The last number I saw, which was about a week and a half ago, was 62% of our PUIs, people under investigation, turned out to have positive tests.
Thank you.
Anybody else?
No, but great presentation and great job. I know how hard you all worked. I've seen what's gone on that campus. It's amazing. So keep up the work and make sure you share our respect to everybody out there doing the work.
Thanks so much.
Fully agree to
Thanks.
that. That's good.
Good. Sounded like an amen, Father Alex.
It's
So,
amen for sure. We're very grateful, very grateful.
Exactly. All right. Well, Ken and Carol and Peg, thank you so much for the update. We could have spent hours with all of you, but we know you guys got more important things to do. And we wish you a lot of good luck. And we look forward to hearing other positive briefings over the summer from you. So thank you again. And now we're going to hear from Judy Greiman briefly on just what the state
And Kevin, I'm not sure if you moved.
financial bleak picture. Running out of power. I had to move. Why? Can you not hear me?
You were breaking up a little bit.
All right. Can you hear me now?
Yes.
Yes, I'm saying, Judy, I'm handing it. I thanked Ken, Carol, and Peg, and I've handed it over to you to brief us on the state financial situation and how it may impact our university.
Okay. So thank you, Kevin, and thank you, everybody. Can you hear me? Sometimes people can't hear me from here.
Yes.
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 So unfortunately, among the other impacts of this are really profound impacts on the university side. And I am sort of calling it the frame of four. We have direct COVID costs that we have already expended and expect to continue to. We will have, as I think Michael referenced, sort of an enrollment mix. Our payer mix will change. And so we've always needed, actually, both for the academic and thought-provoking, but also, frankly, for the financial reasons, some of our international and out-of-state students, and that is obviously at risk. Our state support is, in profound ways, in flux, and I'll get into that a little tiny bit. And then tuition and fees are always something that over which we actually have no control. It's really a SUNY board decision, and they're modest in terms of what they're allowed to do, and we're frankly not sure what in June they will do. And so that's sort of the frame that sits on top of our finances. And obviously, you know, many of these are the same issues that higher ed institutions, particularly research institutions, are facing across the country. We're not different in that way, although I think that's part of our location can play out, and certainly the issues with New York State budget. So SUNY leadership has asked the colleges and universities to prepare for sizable cuts in state aid. And the governor has said that there will be severe economic disruption. I think when I talked, I believe at our last meeting, we had already passed the budget, and at that time, the budget was passed with extraordinary authority given to the DOB. So 3 times over the course of the year, they will be reassessing the budget and then making cuts. That first cut plan is coming out, looking for a significant reduction in spending, all hiring and purchasing put on hold, salary increases delayed. And so all of those will hit us in different ways. And again, SUNY has asked us to prepare some fairly drastic scenarios, just in terms of looking at how we could cut a significant amount of money from our budget. As many of you know, we are pretty lean. We're pretty lean both from an employment perspective, and also, frankly, we've cut a lot of our spend out already in terms of some of our contracting and all that. So we run pretty lean, and it will be difficult to come up with those. We are today announcing that obviously we're following along with the state and the SUNY hold back on hiring and general spending for at least the next 60 days. And we will continue to assess. Obviously, any cuts are going to make this extremely difficult budget situation even more daunting than we had sort of already thought. But it's part of our fall planning. It's part of this is exactly the time of year where we create our budget. And so these are all of the factors that will be going into it. And again, it's sort of the COVID costs, the enrollment mix, what's happening in the state, and then tuition and fees will frame all of this. It's, I think it's going to be a bit of a rocky road over the course of this year. Already, both presidents, so Maury and Michael, have been working very closely around issues of budget, working very closely with Kathy and her team. We're all working very closely with SUNY to make sure that we're in line and lockstep with SUNY as we think things through. But this is the horizon that's now here. So we will, figure out what's next. But I just wanted to give you a very quick update on sort of how the state budget piece. And the only other thing I'll add is that while we have received some federal stimulus funds to help with the COVID expenses, they really don't come close to currently. Hope there's still hope for the next stimulus act, but they currently don't begin to cover the costs that we've already expended in terms of COVID. So we continue to work at the federal level and working very closely with our federal delegation to make sure that they understand the impacts on the university, on research, and that they hopefully, and we're working very closely with the higher ed community around this so that they hopefully in the next iteration of a stimulus package will do some focus, a greater focus on the university sector. So that's my quick review.
Well, Judy, that was very helpful. And if you guys aren't already planning on doing so, I think it would make some sense for you to prepare, with budget B being if the federal government doesn't bail out the state and our local governments, and the government is forced to make drastic cuts of all state agencies, like what that would mean. So in other words, if we got the federal monies and there were no significant state cuts, we'd look at one budget, and if for the states and we face with the draconian cuts, that would be budget B, just so people have a good understanding of what the potential impacts are, and the fact that it really will be of no fault of our own or of the governor or of SUNY Central. So if you were planning on that, great. If not, it's something I would ask you to consider.
And that is a bit of, I think the way that SUNY is, I guess I would say without sort of all of the details of what gets impacted, it's part of what SUNY's, the exercise that we're currently involved in with SUNY, which is around, if you had to take 10% out of your spend, if you had to take 25% out of your spend, what does that look like? And so that's what we are working on currently.
Okay, great. Do any council members have any questions for Judy? Hearing none, we have one last item on our agenda today, and it's an action item that requires the approval of the council. And I understand we have Dr. Ada Furtman here to go over what the proposed changes are to the Code of Student Responsibility.
Yes, thank you, Kevin. And thank you to President Bernstein, President McGinnis, and members of the council for having me here today to present the proposed changes. While this certainly has been an unprecedented and challenging semester, the Code Revision Committee, with representation from both the undergraduate and graduate student bodies, the University Senate, and campus partners, was able to successfully meet to provide recommendations on modifications to the code. As always, the aim of our changes is to be consistent with national best practices and to ensure that our code and processes are student-centered. Hopefully the council has had a chance to review these changes. I will provide a brief overview and then we'll open it up to questions. The first change I want to highlight is on our restrictions from contact. In our review of the code this year, we spent a substantial amount of time discussing the various restrictions from contact that we use throughout our conduct processes. We sought to provide greater consistency in language while also making clearer designations on when certain restrictions could be used. The first instance of a restriction from contact can be utilized when appropriate during the assessment, investigation, and hearing phases of our student conduct process. We're proposing that this be called a temporary restriction from personal contact. The second instance is at the outcome of a case when appropriate, when a student is found responsible for a violation of policy, and this will be called a restriction from personal contact. Again, keeping the language relatively consistent from the temporary to the regular restriction. The final instance is something that in practice we have done, but was not necessarily codified within the Code of Student Responsibility. And this will take place after an investigation concludes and it is determined that a violation of policy could not be substantiated, either through our conduct process and a finding of not responsible, or if through investigation it's determined that the behavior did not violate a policy. But in these cases, it might be in the best interest of all parties to cease contact with one another for a period of time. This will be called a no contact directive and would be issued reciprocally between all parties involved in those cases. The second change I want to highlight is to our closing statements. So during our student conduct hearings, both the complainant and respondent have an opportunity to make closing statements at the end of the hearing. This change clarifies that closing statements are meant as an opportunity to summarize their key points and that no new information should be presented at this time. After closing statements, there's no additional questions during the hearing process, so it would be inappropriate for new information to be introduced at that time. We wanted to just make it clear in the code as to what the purpose of the closing statement is. The next change I'd like to highlight is based on feedback we received, we wanted to clarify who is a confidential resource for students in our sexual misconduct process and who is required to report information to the Title IX coordinator. We utilized language that was recently edited in University Policy P106 to clarify this information in the code. We also updated some language around confidentiality to be clearer within the code as well. Language around mediation in our Title IX proceedings. So the language in this section of the code was found to be vague and confusing for our students as to when and how mediation could be used in sexual misconduct cases. The changes that we're proposing aim to clarify that the Title IX coordinator determines if mediation is an appropriate action on a case-by-case basis, and that it will only be used with the consent of all parties involved. The final modification that I would like to mention is toward the end of the code. It's in the amendments of the code section, and we changed language in the code to reflect that this is an annual review process. In the code, it was listed as a triannual review process, but in all fairness to our students and our staff and faculty, we want to make sure that this is an annual review process. So those are the highlights. As I said, you hopefully reviewed the bulk of the revisions prior to this meeting, and I'm happy to take any questions that Kevin or the council may have.
Hey, Kevin, I got a question. Yeah, so the trial itself, it's not really a trial, right? The students aren't represented by anybody.
Correct. They are not. It's a student conduct process. We call it a hearing because it observes procedure, and if you look through the code, it actually details step by step the process of that hearing. Yes.
So my concern is, you have this situation where a student is not being represented by an attorney. They're making a closing argument. Maybe they have a recollection that wasn't brought up. I think it's probably overly harsh to not allow them to bring that up at that time, and maybe too formal. If they were represented by an attorney and this was a real trial, I would agree with that sentiment, but I can't vote for this if that's in that. So I would like to table this, Kevin, because I think that we really need a real review of some of these things. It seems like this is a little bit becoming more of a legal process, and a student who is at a hearing, you know, is not going to be professionally prepared and probably needs to bring things up whenever they're available to bring it up.
Chris, can I address your concern?
Well, Chris, thanks for your comments. Chris.
Yeah, go ahead.
Well, actually, Joe has some comments to make as well. And Chris, I'll just ask you to hold up on your motion until Adam and Rick speak.
Yep.
So, Chris, to address the concern you had during the student conduct process, during the hearing process, there are multiple times that students are given an opportunity to present their side of the story or the case. The closing statement is at the end of the hearing after they've had opportunities to present their case, as well as ask questions of any witnesses. So it's at the very tail end. They are also provided the opportunity to have an advisor with them through the hearing to advise them on statements they provide. That advisor can be an attorney, or it can be any other individual that they may choose.
How many of them take you up on that?
Most students, especially in our Title IX process, I'd say most students do come with an advisor, and I'd say the bulk of those are attorneys. So they advise their student throughout the process, as well as and they're given a break prior to the closing statements or any statements that they should provide during the hearing process, to take a break to actually craft their statements as things are happening.
And Chris, this is Rick. Can I just add I've served in my prior role actually as a hearing board member, and I think the reason for the clarity in it is so that there cannot be an official end to the hearing itself, because there are many opportunities throughout the person leading the hearing that they reiterate, bring up information as you go along. And so the period of time that's left where they say, okay, go work on anything you want to say in closing as a wrap up, allows just kind of, it's a quick ending so that then the board can deliberate. So having served as a board member, I've never found a situation where this runs into too much of an issue. But I would say the challenge is that people keep bringing up new information in a closing, you never get to end. And so there needs to be a way to end the hearing where new information isn't brought up. And I said that's the point of trying to put this through. But a lot of information, there's a lot of prep work that goes in both from Adam's team and the advisors, so they are fully aware of everything before they come into the hearing room.
I got it, but they're not attorneys. So, and they're young, and they may not realize what they're saying when they're saying it. And I think cutting them off from presenting facts at any time without an attorney, I don't think that serves the purpose of an educational review, disciplinary review. I think that, I don't know what the rest of SUNY's doing and what the standard is, the best practices across the country, but maybe we need a review of that and see where other institutions are in this matter. That might make me feel a little bit more comfortable, but I'm uncomfortable cutting students off from presenting facts. Just, as an attorney myself who've walked into situations where I picked up representation where people have not been represented and have made cases. And as a former student leader who's, dealt with some of this granted a very long time ago, but I'm interested in what the students think. I'm interested in what the best practice is around the country. And I haven't heard that presented or saw that in the presentation here today. So I'm not saying that it's a no, but I'm uncomfortable with an unrepresented student being told they can't present facts, because how would they have even created their case?
So I'd like to jump in here, because as a public institution, of course, the 14th Amendment does apply to us, and the hearing process has to be fair. Fairness is embedded into anything we do. We've been working with this and revising it since 2013, and we were way ahead of schools like Harvard and other schools that they were tipping the scales in one direction or the other. We felt acutely aware of the fact that there had to be equal representation and there had to be a fair process. So every year when we come to this council to ask for tweaks in the code, it is part of that longstanding refinement process. We've also been challenged in court, which every school has, and we've been highly successful in prevailing in most of those challenges. Anyone will sue anybody for anything. Since this is a once-a-year process, and we do have a very refined code which has been following practices with the AAU and with colleges all around the country, and again, we were way ahead of the curve on this. I think it would be throwing out the baby with the bathwater if you tabled for a year at least all the other changes that have to be made here, because there are important tweaks to the code. And so I want to assure you, Chris, that what you're talking about, looking at other standards, is something that a very sophisticated team has been doing for 6 years now. And it's not that I don't hear your concerns, and we are aware of the fact that students who come unrepresented, and most of them do not, especially in Title IX. We have one of my attorneys is at almost every one of those hearings because there is an attorney present.
Right.
So I hear what you're saying, but I also want to assure you that these concerns are addressed every day. And if you have any other questions on a more granular level, we'll try to answer them for you.
Kev, you froze.
Well, and either you or Adam, can you hear me now?
Yeah.
Yeah. Yeah, I wanted to thank Susan and
Now you're breaking up.
for the comments, and just to educate also. Is this any better?
Yeah, for a minute.
Sorry, guys. I'm saying I
can't.
Or Adam or Sue to do this. We expect all our students.
We're losing you.
All right, I'm going to try one more time. I was banished to my office in the basement. Can you hear me now?
Yes.
Yes. Okay. Susan or Adam, please confirm. We need to approve this.
Yes.
Because we expect the students to sign the code of conduct before the start of the semester. Is that correct?
That is correct. The new code goes into effect August 1st at the start of this semester, and then Rick provides notification to all students of any changes that have been made since the previous year.
So Chris, without dismissing any of your legitimate concerns,
I'm losing you.
Can't hear you, Kevin.
Yeah, we're losing you.
That we approve
Can't hear
this,
you, man.
but we do take a look at the concerns you raised. Sorry, I'm going to ask that we. I'm going to ask that we move this, and Chris will take a look at your concerns in the future, just so we meet the deadline.
Before we move it, why don't we just amend it, take out that offensive part, come back to that in September. We can make an amendment to the code then with closing statements rather than move the entire package. You know, and we could see what other schools are doing and what the process was that developed the end of this. I hear what they're saying. I'm just concerned about it.
Okay.
You know.
Adam, Judy, is that something we could do?
So we do the revisions once a year because we bring people in under a code. And so we can't have them sort of coming in at different parts of the year with different codes. And so I think if we didn't do it now, frankly, we would either need to do sort of a quick special meeting in the next month or not do it until next year. We just can't have students coming in under different codes.
Well, I mean, I don't see the rush to have this part of the code put in, frankly. I don't see the urgency. So I would make a motion that we strike the segment about closing arguments, and then we pass it without that. And then if there's a way for us to pass it before the school year, great. If not, we'll do it next year.
We also had a special meeting last August for the same thing, didn't we? So is it possible?
I think we did.
Yeah.
Oh, yeah, we did.
And Francesca, did you or Shahir have any other specific comments regarding these changes to the student code of conduct?
No, if there's interest to share it with other students, which I do, I didn't have time to do that. So given your comments, Chris, I will elect to do that.
All right. Okay, so listen, guys, it sounds like there was a motion by Chris, seconded by Francesca. Adam, if we need to, regroup on this in the summer, we will. But there's a motion, there's a second. I'm going to ask the council members for a vote. All in favor of Chris's motion?
Wait. I just want to clarify before we vote on this that we're voting to strike that one part, but then move the rest of it, correct?
Correct.
Okay. And can I ask a question before we move it? I have one question for the
Linda.
staff. By striking that, is there any unintended consequence to the student population that we're not aware of?
I think the only unintended consequences is not making that section more clear. In practice, students typically do not present new information during closing statements. We did have it come up during a hearing this year where a respondent declined to participate during the investigation process and did not want to present any information during the previous stages of the hearing because he could be asked questions based on those during the hearing. And he wanted to only present his case during the closing statements, knowing that no one could ask him a question after that point about any of his statements. So we wanted to try and prevent that from happening in the future, which is really the impetus for presenting it this way moving forward.
All right, but there's no extra harm to the students based on us striking it temporarily.
The only extra harm there would be if somebody did that because, as Chris said, they're a student, they're inexperienced. If the other student didn't have a chance to cross-examine, that would be a constitutional harm. So I think that goes to Adam's point, is if they bring it up, then you have to just keep going because you do need the back and forth in order to make it a fair and proper hearing.
Okay, then I think we should try and get back together over the summer or next month to address Chris's concerns so that we do start the new school year off correctly. And I don't think any of us, especially with our Zoom capabilities, would object to another meeting, but I think we should move the rest of it. And my question was answered, so thank you.
All right. And you know what? If there are going to be some draconian budget cuts, we may need to regroup because we may need to approve some draconian program elimination or something. So I'm not adverse to us getting together again. So
we're back to moving
the
Chris's
motion is
amendment.
made. There's a second. Yes. All in favor?
Aye.
Any opposed? Any opposed? No. And the motion, as Chris said, is approved. Does any other council member have any other business to bring before this council meeting?
Did we actually approve the rest of the amendment, or was that all wrapped up into one vote?
It was all wrapped up into.
Okay. I'd like to request that we put a tentative meeting on the calendar so we all have it on a calendar.
One motion minus a strike by Chris.
Okay,
well,
great.
I'll ask Judy and Rachel to send something out.
Even if it's just a placeholder so that we have something.
You will.
Thank you.
For some time in August, that's fine. I don't have a date yet. Work on that as well. Michael or Maury, anything else before we adjourn?
Nothing from me, Kevin.
Thank you, Michael, and your team. Maury, any final closing comments?
No, just so look forward to working with you all, and sounds like I'll be seeing you in August, if not before then.
Yeah, very, very good. Again, I just want to thank the incredible team that's over at Stony Brook. It never ceases to amaze me. I'm always impressed with what's going on and the people who are working on the issues. And as I said, there were so many important issues today. We could have spent the whole meeting on just some of these subtopics. But we will be grouped. You know, we're supposed to have a minimum of 4 meetings a year. Nothing prohibits us from having more. And if we need to have another meeting over the summer, we'll do that. So with that, I want to thank you. Stay safe, stay healthy, and we look forward to further updates regarding fall semester, as well as anything important from the hospital side. So I thank you all, and have a good day.
Thank you, everybody.
Thanks, Kevin.
Thank
Thank
you.
you.
Thank you.
Thanks, Kevin. Bye, everyone.
Bye now.
Bye.